Hello and welcome again to the Emergency Medicine Clinics podcast. I'm Patrick Manley, the managing editor for the series here at Elsevier. Emergency Medicine Clinics is a quarterly publication consisting of review articles on a central topic. Today we'll be discussing the May 2015 issue on orthopedic emergencies. Joining me are the guest editors of this issue, Drs. Della-Giustina and Katja Goldflam of Yale University. So it's been several years since we've covered the topic of orthopedic emergencies. Dr. Della-Giustina, what new treatments or procedures have you found to be particularly exciting in the past few years?
Well, what I've seen that I think to be most interesting and the most advances in terms of managing of orthopedic emergencies in the emergency department is advanced imaging from the emergency department. It's become much more available and much more commonly used in the ED in the management of our orthopedic patients. Specifically, in regards to spinal imaging, plain radiography was the standard of care, and it was always all that was readily available. Now, CT scan is much more commonly used as the initial imaging modality of choice, and those with multiple injuries or in those where there's a high suspicion of injury. And so that's a big change. And then also, in addition to CT for spinal imagery, is also MRI. It's much more available and utilized much more in those patients who have a high level of suspicion for injury, or if they have something abnormal on their plain films or on their CT scan, they're going to follow it up with MRI out of the emergency department as opposed to, just assuming what they see on the imaging is normal. Another example with the advanced imaging is the use of CT angiography with those who have a knee dislocation and a concern for popliteal artery injury.
I've actually done a few issues over the years on orthopedic emergencies. And one thing that really stands out to me in this one is a great variety of authors from all different institutions. Dr. Goldflam, what was your approach for the areas to be covered in this issue and in finding authors to cover it?
Yeah, I think we just wanted to get a broad range of authors sort of from different backgrounds to make sure that we really get the best experts in the area. And so it's a selection both from our own institution and a few others. And I think we wanted to make sure, again, that we could really cover the range of orthopedic topics that we see in the emergency department really on a day-to-day basis. So I think a lot of this is really the bread and butter of emergency medicine, and I think we've gathered a great selection actually of authors that have done a really good job in capturing sort of what every emergency physician needs to know.
Dr. Della-Giustina, your article, Evaluation and Treatment of Acute Back Pain in the Emergency Department, what were some of the pearls and pitfalls from this article?
Yeah, so what I would say is there's a few issues of importance in managing patients with back pain. And really, first is the emergency provider needs to focus their evaluation on the red flags in both the history and the physical examination and use that to guide their evaluation and further treatment of the patients. And so just to go over those really quickly, because I think they really are important and they will make a huge difference, is the red flags in the history are duration greater than 6 weeks, age less than 18 or older than 50 years old, major trauma, or minor trauma in the elderly patient, any patient who has a history of cancer, fevers, chills, and night sweats, weight loss, a history of or currently an injection drug user, immunocompromised status, a recent GU or GI procedure, night pain, unremitting pain, pain that's worsened by coughing, sitting, or Valsalva maneuver, pain that radiates below the knee, saddle anesthesia, and then a severe, meaning more than one nerve root involvement or rapidly progressive neurologic deficit. And so those are the ones in the history that you want to focus the questions on to try to see if you need to evaluate them further. The red flags in the examination are fever, anal sphincter laxity, perianal or perineal sensory loss, major motor weakness, and again involving more than one nerve root, point tenderness to percussion, and a positive straight leg raise test. And then in the patients, as you go through and evaluate them, if the red flags raise your suspicion for infection, you should do lab testing to include blood cultures, because patients can develop, or if they have a spinal infection, about 60% of the time the blood cultures will be positive. So you truly want to do blood cultures on those patients, but also a CBC, an ESR, a CRP, and a urinalysis. And then if you're really worried about infection, you really can't use the lab tests to tell you whether an infection is ruled in or ruled out. You have to use an MRI because it visualizes the vertebral bodies as well as the discs, and inside the spinal canal, which you would miss if you did just a CT scan on those patients. If you're worried about epidural compression, you should potentially treat the patient with dexamethasone if you think the patient has an epidural compression due to a tumor. And you do that early while you're awaiting advanced imaging for the patients. And then MRI is the imaging modality of choice to best evaluate those patients for epidural compression. But really what's going to happen with the majority of patients we see in the emergency department, the red flags are all going to be negative, and you're not going to have any concerns about them having an infection or an epidural compression or a fracture or anything serious. And really, we're going to call that nonspecific back pain, and you should treat them with nonsteroidals and or acetaminophen depending on whether they have allergies or renal disease or peptic ulcer disease. Strongly consider opioids as an additional treatment, but if you're going to prescribe them, it should be for only a short period of time, and then giving them appropriate return precautions. So it's going to take time for them to get better, but you want to talk to them about, if they have worsening pain, numbness, weakness, incontinence, any of those, and you want them to return back to the emergency department to get managed.
One thing I especially liked from this article was the breakdown of approaching back pain in someone with a history of cancer and all the different group classifications. I thought that was really well broken down. Yeah,
that's a group of patients that we're seeing more and more commonly in the emergency department, and you really don't want to miss a patient who's got cancer and has metastases to their back. So that breaking down by those three groups gives you a good approach to try to figure out what's going on with the patient. Really, group one is they have a history of cancer, but everything's normal. Then group three is they have a history of cancer, but they have epidural compression. So those patients, you want to be really cautious with them and make sure that you evaluate them properly and kind of follow the algorithm that I put in there by breaking them down into those groups.
Great, thanks. Dr. Goldflam, let's look at your article on the evaluation and treatment of elbow and forearm injuries in the emergency department.
Yeah, I think, again, this is one of those topics that pops up over and over again. It's hard to go through a shift without, having people with all kinds of orthopedic issues, but certainly elbow and forearm, I think, are one of the more common ones. And often these are from foosh injuries, so fallen outstretched hand or direct blows, especially older females and young males are sort of the obvious categories, which is frequently something we see in the epidemiology, sort of those categories of patients being victims to these sorts of injuries. And again, you can get fractures, you can get dislocations, sort of combinations of both. And so I tried to subdivide into those categories so that we could just sort of look at the specific patterns of injury and how to sort of image, treat, and manage the patients. And dislocation actually of the elbow is the second most common type of dislocation in adults, right after shoulder dislocation, and actually the most common in kids. So again, something that every emergency physician needs to be able to handle. And I think the key is always to assess the neurovascular status, just because you want to make sure that you don't miss any of those sorts of injuries in addition to the obvious, probably more obvious fractures. The elbow, because it has this three-dimensionality, the mobility is much larger, and so any limitation really will give you a pretty restricted range of motion. So your goal as the EM physician really is to make sure that you have anatomic alignment of any fracture or dislocation that you find on imaging or that you suspect, if you suspect it based on clinical exam. And most of the time these patients are going to need pretty urgent operative intervention. So frequently the orthopedist will actually take people with elbow or forearm injuries to the OR within 24 hours. So these are really people that you want to make sure have good follow-up, if not a consultation in the emergency department. And non-displaced fractures, sort of simple fractures, can be splinted, and really you have to make sure that the patient is aware that they should start early range of motion, just because any delay in that can actually cause stiffness, especially in the elbow joint, which in the long term can really cause a lot of morbidity. Elbow dislocations, as I said, second most common after shoulders in adults, are really within the purview of the emergency physician to relocate. So something that you should be familiar with, and we talk about some of the techniques in the article. Forearm fractures definitely can also affect the distal radial ulnar joint and also the intraosseous membrane. So I look at a couple of the different patterns, Monteggia fracture, Galeazzi, those are sort of common ones that also pop up on board exams. So I think in that regard are sort of important to know about. But like I said, the interosseous membrane or the radial ulnar joint can be affected. One example is the Essex-Lopresti fracture, where you actually have a radial head fracture and a disruption of the distal radial ulnar joint, and you tear the interosseous membrane. So something like this, you really might be focusing on the fractured radial head that's really obvious on the x-ray, but you really have to maintain a high suspicion for damage to the interosseous membrane. These kinds of things, if they're missed, you can actually end up with pretty significant morbidity in the long term, just because the radius can actually migrate forward and cause instability and misalignment if this is missed. So again, a lot of these are pretty straightforward, but you just have to maintain a high suspicion, especially some of the injuries don't have obvious findings on imaging. So we talk about all of those, and I think, again, frequently seen in the emergency department. So.
Yeah, as someone who has unfortunately fractured their own radial head in the past, I found that discussion very interesting.
Yeah. So you know the pain and probably more delayed morbidity associated with that.
I just want to take a quick pause here to let our listeners know they can receive an exclusive discount on the issue we are discussing today by visiting us.elsevierhealth.com/EMC podcast. Let's go on to Dr. Della-Giustina. Let's talk about the emergency department evaluation and treatment of shoulder and humerus by Bonds and Tindloy.
Yeah, sure. Shoulder injuries are interesting because they're really common injuries that are seen in the emergency department, whether it's a dislocation or a fracture or an AC separation. But there's a couple of important points that I kind of got out of these articles here, or this article here. The AC dislocation, which is a very common injury, so the acromioclavicular dislocation is a very common injury. We see them all the time in the emergency department. And, early on in my training, I learned that there's only 1 through 3 types, and most of them were not operated on. But subsequent to my training, afterwards, we found that, there's actually, they reclassified it as 6. And there's several of them that actually end up going on and need operative repair. And so I thought it was interesting, and it's something that I really thought is important to cover in this podcast here. Like I said, most of the time we will be able to treat all of these in the emergency department with a sling, with analgesics, and get them followed up. Whether it's grade 1, 2, or 3, most of those will be able to follow up with their primary care doctors and not necessarily need to see an orthopedist unless there's some other concern, because most of those are not operated on. However, there's the grades 4, 5, and 6 who generally need operative repair, and I wanted to just review those because I think it's important to understand that there are these grades and that they actually do operate on several of these. So a grade 4 is a dislocation where the distal clavicle is just dislocated posteriorly and it goes back into the trapezius. And so the way that you're going to recognize this is as you look at the patient, you're going to notice the clavicle is dislocated posteriorly, and it seems to be actually into the muscle of the trapezius. And that ends up having to be operated on, pulled out of the trapezius, and stabilized. A type 5 we commonly see, and we kind of used to classify it more as a type 3, but the type 5 injuries where you have a severe type 3 injury, where you have a complete AC separation, and the distal clavicle is really sticking up high, almost tenting against the skin, because the dislocation is so significant that not only did it tear through the acromioclavicular ligament, but also the corticoclavicular ligament, which goes along with the type 3, but it also stripped the trapezial and the deltoid fascia from the clavicle and the acromion, and so there's absolutely nothing that's holding the distal clavicle in position. And so, again, these are commonly operated on. And then finally is the rarer class 6, and it's a inferior dislocation of the distal clavicle so that it sits either in the subacromial space or the subcoracoid space. And you would be able to pick this up both on examination, but certainly on radiography. And these are ones that you don't have to have the orthopod see in the emergency department, but it's one that you want to ensure that they get, emergent follow-up in the next day or two, because they're going to evaluate them, and there's a good chance they will take all 3 of those to the operating room. And again, it really depends on your referral pattern and your relationship with the orthopods in terms of how quickly you see them and how you get them in to be seen. Shoulder dislocations, there's a long discussion about the various types of shoulder reduction. I don't really want to go much into the shoulder dislocations in terms of reducing them, other than individuals are going to use the type of reduction technique that they've learned in their residency and they've learned over a period of time. And whatever works best for you is probably the best method to use in terms of reducing the shoulder. However, the one much rarer shoulder dislocation I wanted to cover is called the luxatio erectae, or the true inferior dislocation. Now, this one covers occurs less than 1% of all shoulder dislocations. And what it is, it's a true inferior dislocation where the humeral head is inferior to the glenoid of the scapula. And so this one's interesting because, one, it's rare. Two, the patient typically comes in with their arm in a fully elevated position over their head. And they can also have significant soft tissue injuries associated with this, specifically avulsion of the supraspinatus and pectoralis major muscles. And that's uncommon to see in any of the other dislocations. So it's a higher risk injury that occurs much more rarely. And then the reduction technique for this is longitudinal traction using a counter-traction method and a deduction of the arm as you start to reduce it. So most of these, in my personal experience, is that I've been able to reduce all of these in the emergency department without having to send them to the operating room. But you really have to be cautious about these in terms of evaluating them for other muscular injuries as well as involvement of the brachial plexus. So you want to make sure you do a good neurovascular examination on these patients because the amount of trauma that causes the dislocation as well as the location can cause more significant injuries.
Thanks. That's a very thorough breakdown of that article. Dr. Goldflam, what stood out to you in the emergency department evaluation and management of foot and ankle pain by Wedmore, Young, and Franklin?
I like the stood out. I wasn't sure if that was planned, but yeah. I mean, I think I think we cover a couple of key examples. And again, this is sort of one of those things that you really can't go a shift in the emergency department without seeing. And I think one of the key things that they talk about is actually the Ottawa foot and ankle rules and the Ottawa knee rules. I think a lot of the orthopedic injuries really lead themselves to over-imaging. And so I'm really glad that they highlighted this in their article. The Ottawa foot and ankle rules that they go through basically include walking 4 steps in the emergency department, tenderness to palpation over the navicular bone and the head of the 5th metatarsal, and then also tenderness of the bony tip along the posterior edge of the distal 6 centimeters of the medial lateral malleolus. Again, if you know those rules and you apply them in a clinical setting, you can actually help reduce x-rays or imaging by 30 to 40%. So that's a pretty significant amount of both time and money and radiation saved. And so, I think one of the key things here definitely is a good, thorough physical exam, especially, again, as I've mentioned before, the neurovascular exam to make sure that you're not missing other injuries. They mentioned sort of a couple of specific examples. Calcaneal fractures, I think, is one where you have to be really aware that they're associated actually with 10% coexisting spinal injuries in patients, just because it implies, or whenever you encounter someone with a calcaneal fracture, you should really be thinking about the significant impact that it's taken to cause this injury. So that 10% of coexisting spinal injuries in that patient population is something you really don't want to miss. And then just a few other examples, fracture patterns that they talked about. A lot of them will require ORIF and surgery, so you need to make sure that these people have good orthopedic follow-up, if not consultation in the emergency department. One example is the Lisfranc fracture that frequently needs surgery and is often not seen on X-ray or CT. So again, you have to have a high clinical suspicion for that. The trimalleolar fracture, I think, is the one we're most familiar with needing surgery for, obviously a very unstable fracture. And another example is the Maisonneuve fracture, where it's kind of similar to the Essex-Lopresti one I mentioned in the forearm, where you actually have not only a medial malleolar fracture, but disruption of the intraosseous membrane and a proximal fibular fracture. So again, a very unstable injury where if you don't do a thorough exam and really, not just focus on the ankle where their primary pain might be, but actually examine the proximal fibula as well, that's something that you might easily miss. So really important to do a full, complete exam and not be distracted by findings on physical exam or on X-ray that, it's sort of the distracting injury theory, just like in C-spines, where you need to make sure that you do a complete exam and not just focus on the really obvious things to make sure that you minimize morbidity in the long term if you do miss other injuries.
And I thought that this article in particular was one of the best illustrated articles in the issue.
Yeah, I agree. I think a picture's worth 1,000 words, right? And at least 2 podcasts.
For this next section, I was going to do a very quick key takeaway from each of these articles. The first one, Dr. Della-Giustina, do you have a key takeaway from emergency department evaluation and treatment of pediatric orthopedic injuries?
Yeah, I would actually. There's a couple key takeaways. Number one is always remember the growth plate and the Salter-Harris fractures. At a minimum, if they're tender over the growth plate, they should be immobilized and treated as a Salter-Harris 1. And then always think of child abuse and non-accidental trauma when you're evaluating any of the pediatric patients with injuries. It's got to be something that you always think about and in your mind when you evaluate them. How is this not child abuse for that child?
The next one I would ask you is Orthopedic Emergencies, a practical emergency department classification in pelvic fractures.
Yeah, they do an interesting job with breaking down a classification system that's more emergency medicine focused, with trying to evaluate the stable versus the unstable pelvic fracture, and then how to evaluate it based on the injuries. And so I think they do a great job with that. The one key point I got out of this article that I think is important is understanding the Cryers criterion, and you should really be concerned about any patient who has a pelvic fracture with 5 millimeters or more of displacement measured on the AP pelvis film, because it's associated with significant hemorrhage. And we see a lot of patients with pelvic fractures, and 5 millimeters doesn't seem like much, but the literature shows that it is highly associated with potential vascular bleeding and hemorrhage.
Yeah, actually, I don't know that we've ever had an article with this classification system before, so it was very interesting for me. Dr. Goldflam, how about a key takeaway from emergency department evaluation and treatment of cervical spine injuries?
I think to me it was interesting to look at their discussion of CT versus X-ray, and I think the key point there was really just to make sure that you really select your patients carefully that you do X-rays on. We find it frequently here that the radiology read ends up being sort of a bit of a hedge, which is understandable because the imaging is not quite as sensitive as CTs. Obviously, it is a higher cost and radiation certainly in doing CT scans, but I think your bang for your radiation buck, so to speak, is certainly much better in CT scans. X-rays, lower radiation, certainly for a select population, is probably the better choice, but anytime that you have someone with severe osteoporosis, arthritis, malignancy, sort of higher age groups, those are the ones where probably going straight to CT really has become essentially the standard of care at this point. And
how about a key takeaway from evaluation and management of traumatic knee injuries in the emergency department?
I think the big one for this is don't miss popliteal injuries. And really, if there's a dislocation of the knee, this is something you need to absolutely be thinking about. And you should be doing an ankle brachial index, so ABI, to measure the ABI on patients where you suspect it. If it's anything less than 0.9, you should be doing a CT with vascular imaging. I think that's really something that is, if you missed it, that would really be a major miss. And so to keep that in the forefront, I think they did a good job highlighting that.
Excellent. At this point, I'd like to make room for any kind of final comments you may have. Dr. Della-Giustina, let's start with you.
I would just like to say that this is a good addition to cover most of the bread and butter things that we see in emergency medicine with orthopedic injuries and emergencies. It's very up to date in terms of the literature, in terms of imaging and the operative treatments. Not that we're going to operate on them, but the ones that we should be sending to the OR. And, our authors did a great job with all the chapters that they wrote.
Great. Dr. Goldflam, any final comments?
I would, definitely second that. I think the authors did a fabulous job. I actually had a meeting with one of my residents who saw the book lying there and requested that we hand it out for all of the orthopedic rotating residents. So for when our EM residents are rotating on the orthopedic service. And I think that's a great idea. I think it covers a lot of the key topics, really, as we said, the bread and butter of emergency medicine, which I'm excited about.
Thank you for joining us for this edition of the Emergency Medicine Clinics podcast. For an exclusive discount on the issue we discussed today, focusing on orthopedic emergencies, visit us.elsevierhealth.com/EMC podcast. Emergency Medicine Clinics is available for individual print subscription with accompanying electronic access, as well as on the Elsevier electronic platforms Clinical Key and Science Direct. A CME program is also available. For more information, visit info.theclinics.com. Be sure to follow us on Twitter @eMedClinics and subscribe to the Emergency Medicine Clinics podcast on iTunes. Upcoming issues of Emergency Medicine Clinics will focus on cardiovascular emergencies in August, psychiatric and behavioral emergencies in November, and in February, respiratory emergencies.